Hello, everyone, and thank you for joining today's program on emerging options for neuropathic pain management, presented by the Foundation for Peripheral Neuropathy. This has been a very hot topic of our patients who suffer from peripheral neuropathy, and I'm so excited to be able to work with our expert speaker to provide some facts and some treatment options for those suffering from painful symptoms during this hour-long webinar. My name is Lindsay Colbert, and I am the Executive Director of the Foundation for Peripheral Neuropathy. On behalf of the organization, its staff, and dedicated board members and volunteers, I just want to thank you again for entrusting us with providing valuable educational resources as you navigate your journey living with peripheral neuropathy. Before we begin today's program, I just want to quickly remind everyone of a few logistical items. First, yes, we are recording today's live program and it will be emailed to all registrants and also permanently housed on the FPN website along with the accompanying slide deck for future reference. Second, for those who are in attendance live today, we will be carving out time at the end of the presentation for a live Q&A. Please use the questions box in the dashboard of this platform to type out any questions that are general in nature and on topic. We will not be able to answer any personalized medical questions today, rather answer questions that are helpful to the greater audience. And we will try our best to answer as many as we can. And lastly, we do offer closed captioning for those who are in need, and that can be switched on in this dashboard as well. And now I am pleased to welcome and introduce our expert today, Dr. Alexander Chamessian, who is an assistant professor in the Department of Anesthesiology at Washington University School of Medicine in St. Louis. Whew, that's a mouthful, where he works within the Division of Pain Management. His clinical focus is on the study and treatment of neuropathic pain, while his research investigates the pathogenesis of this condition and the development of novel treatments. Dr. Chamessian's work aims to improve both the scientific understanding and therapeutic approaches to neuropathic pain, helping to advance care for patients suffering from this debilitating condition. And with that, I'm excited to pass the virtual microphone over to you, Dr. Chamessian. Thank you again.
Thank you, Lindsay. All right. Just get my slides here. Let me just real quick make sure we're working. All right, everyone. Thank you, Lindsay, so much for the very kind introduction and this wonderful opportunity to present to the audience here. Just making sure my slides work. Sorry, everyone, we're just getting the webinar stuff here. But I'm going to talk to you today about pain management for neuropathic pain related to peripheral neuropathies. We're having some issues here with the slides, Lindsay, so I might need you guys to advance for me. Can we go to the next slide, please?
Yeah, sure thing, Alex. Sorry about that. We'll try it one more time on our end.
Okay, thanks.
And if it doesn't work after this slide, Alex, then we're more than happy to advance it on your behalf. Apologies.
All right, great. No worries, thank you. So before I begin, just some disclosures. Some of the devices and interventions I'll talk about, I've received support to get training on how to implement them, including from Medtronic, Boston Scientific, and SPR Therapeutics. Next slide. Okay, so I think it's first important that we have some shared kind of terminology. And so let's just talk about a couple of terms we're going to be using throughout this discussion. First, peripheral neuropathy, as many of you know, is basically a disease of the peripheral nervous system, which can include motor, sensory, or vasomotor, also known as autonomic nerve fibers. Pain, which is the central topic of today's talk, is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This definition comes from the International Association for the Study of Pain. And I think what I want to highlight here is that it's an experience. This is something that only someone can tell you who is conscious, awake, and feeling it themselves. It's not a thing that you can visualize on a microscope. It's not something you can image on an MRI. It's not something you can measure with electrodes. It's an experience, and I think that's what separates it from many other things that we study in medicine, and that we can, and even about neuropathy. For example, weakness, which is a motor dysfunction, you can generally, others can observe that, but one can't get inside the head of another person unless they share it with you through their words about what they're experiencing. And I think it's important for us to remember that. Neuropathic pain. So there are different kinds of classifications of pain. Neuropathic pain, which is the central focus of today, is pain caused by a lesion or disease of the somatosensory nervous system. So that part of the nervous system that subserves or works for sensation of the world around you. And then nociceptive pain, which is, I think, what a lot of us think of as kind of normal pain when you, for example, stub your thumb with a hammer, or you put your hand on a hot stove, is pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of nociceptors, which are a type of neuron that serve the sensation of pain. Next slide. So with those definitions under our belt, now we kind of have shared language to talk about about neuropathic pain and how we can manage it. So a little bit more. So what does this look like? I think all of you tuned in today are probably have your own words that you would use to describe how peripheral neuropathy affects you. But I think what's important also to highlight here is that peripheral neuropathy encompasses many different diseases of the peripheral nervous system, many of which cause sensory abnormalities, pain being a prominent one, but not all of them. There are neuropathies where the only problem is weakness, where there's predominant motor dysfunction. And there are some neuropathies where the predominant issue affects the autonomic component, so resulting in symptoms like, orthostatic hypotension, so not able to regulate your blood pressure when you stand up, or heart rate abnormalities. But I think many folks here, what we're going to talk about today is the sensory component, which tends to show up in many kinds of peripheral neuropathies. I'll also mention that pain is not the only sensory abnormality. So I have patients I've seen for whom numbness, meaning lack of sensation, is their main concern. They have no pain. So they have profound neuropathy, profound loss of function of a component of their peripheral nervous system, but pain and other kinds of abnormal symptoms like tingling and pins and needles, etc., are not part of their experience. And so, it's important to recognize that neuropathy affects people in various ways, but pain, I would say, is by far the one that people come for treatment the most, because it is so debilitating and affects one's life so much. Next slide. As I said, neuropathic pain is pain caused by a lesion or disease of the somatosensory nervous system. So what is that nervous system? I just want to give an overview of kind of the parts of the nervous system we're talking about. And it's vast. It goes from foot to brain, from the little microscopic terminals that innervate the skin and the muscle and the tendons and bone, right? Those are the little fibers that come out from larger trunks of fibers, which are the nerves. And then the nerves, they join up at the level of the spinal cord, which you can see on the left there. And then from the spinal cord level, all of those axons, all those wires have to go all the way up to the brain, where the conscious experience of pain occurs. But anywhere along this path, there could be an abnormality that may lead to sensations like the ones in the top corner: pins and needles, burning, numbness, electric shock-like tingling, and an abnormality along any. And so really, this entire nervous system, in a sense, is fair game for where there might be a lesion or a disease that could lead to the things that we're talking about today. So what are the actual causes of peripheral neuropathy? Also vast, but I highlight here on the right in a table the most common known causes of peripheral neuropathy, including diabetes, shingles, chemotherapy, HIV. But then you'll also notice at the bottom there idiopathic, which is a fancy word of saying we don't know. And and I suspect many in this audience are in that situation where we can say that you have a problem with your nerves. You experience the pain as described by these words, or probably in words that we don't even have good words for, but no one can say the cause. And this is very frustrating for many. But being honest about what we do and don't know, even though we have hundreds of causes of peripheral neuropathy, for many people who go through the diagnostic process, we can't ever say for sure. But that doesn't mean that we can't do anything about it, which is what we're going to talk about now. Next slide. So just to kind of give a sense, so I'm a pain management specialist. I see people specifically for pain. I want to distinguish that from neurologists, who are my colleagues, and probably the entry point for many of you in getting the label of having peripheral neuropathy. They neurologists or other physicians typically will do the comprehensive evaluation and diagnosis of someone having a peripheral neuropathy and begin the treatment process with the interventions we're going to talk about, usually pharmacology. But when that's not sufficient, folks will come to someone like me, where I work in a dedicated setting where I focus not so much on diagnosing the neuropathy anymore. That's usually already done by the time someone comes to me, but for understanding and treating the pain that has been resistant to many of the first-line therapies. And to just give you a sense, and I suspect many of you have may already be working with a pain management specialist, but to give you a sense of what that process and kind of what that experience looks like, before someone comes to me, I will do a thorough review of the medical chart, the things that have already been done. Like I said, typically they've come with extensive evaluation from a neurologist or other physician. An important part about understanding someone's pain is that, unlike, let's say, cancer, where you're looking at scans of tissue and you're looking at blood tests, here, because it's an experience, what I really care about is what someone tells me about what they're feeling. That ultimately, that is the final, that is the truth about about this person's problem. It's not a piece of tissue that I can measure on a CT scan. And so before my patients come, I will send out these validated questionnaires that ask questions that many, seem straightforward, but help me get a good sense of what are the ways in which a person's pain is impacting them. And then when we meet together, I collect additional history, do a physical exam to help kind of winnow down diagnostic hypotheses about what I think is going on. We get additional diagnostic information if we need it, and then finally we come up with an assessment and plan. And the assessment and plan part is what we're going to elaborate on more today, and especially the things that a pain management specialist can do uniquely. Next slide, please. We're just going to go past this, so let's go a few slides, please. I'm going to skip through a couple things just because please stop there. Yeah, for the interest of time. So I want to make an important distinction, and I think I've gotten a lot of questions from patients, and I want to really hammer home what it is that I can do and what actually honestly anyone can do. So some branches of disease, some types of diseases, we have curative or causative therapies where we're getting rid of the problem. Like, we understand the problem and we remove the problem. Like, a good example of this would be if someone has an infection. Let's say you have pneumonia. We know that the causative organism is usually, let's say it's some bacterial infection. We give an antibiotic. The antibiotic eradicates the bacteria and the problem resolves. That I think that is what everybody would love to do about most kinds of diseases. But not every ailment is amenable to curative or causative therapy, either because we don't know the cause, or if we do know the cause, we don't have methods of eradicating the cause. So, for example, if someone is born with a genetic disease, let's say cystic fibrosis, there have been tremendous advances in affecting how that disease affects someone's body, or modulating how that disease affects someone's body. But at the end of the day, that underlying cause, the aberrant gene, is a part of that person's fabric. Or something maybe a little less exotic, like, let's say, congestive heart failure. That is a disease that is chronic, and we can't really reverse the cause, but we can manage the symptoms. For many, peripheral neuropathy and neuropathic pain that comes with it is in the managing the symptoms bucket, because either we don't know the cause, like in the case of idiopathic, or even when we do know the cause for something very common like diabetic neuropathy, we can do things maybe to halt the progression, but it's very difficult to kind of turn back the hands of time and normalize the system to the pre-morbid state. And so, as unsatisfying as it might be to just kind of come right out and say it, a lot of what we're talking about today is to make living with the disease better, not necessarily getting rid of the underlying cause of the disease. And so I use this analogy here of a hole in the roof and a bucket. So the end point, let's say, is you're trying to keep the floor dry. And you can imagine two ways of doing that. Either you fix the roof, right? Like you patch the roof so the water stops coming, or you put a bucket underneath of it. From the perspective of someone down on the ground, both manipulations, both interventions would keep the floor dry. But one of them will permanently keep it dry and take care of the issue at its heart, and the other is just kind of mitigating the effect of it. I think all of us would love to fix the roof, but a lot of pain management is catching it in the bucket. And if keeping the floor dry is what we'd like to do, and even if we can't necessarily fix the roof, we have a lot of tools that can achieve that in a way that I think can ultimately make people's lives better and satisfying. But I just want to highlight that what I'm talking about here, and what a lot of what we can do in pain medicine, is not causal therapy. It's going to be symptom management. Next slide, please. So what are the goals of pain management? What are we trying to achieve? So significant pain reduction. What that exactly looks like for each person is going to differ, but some estimates are just kind of general benchmarks are maybe a 50% decrease in someone's pain intensity. We care a lot about not just how someone rates their pain, but also restoring their function and their abilities. What is pain keeping them from doing? Can we bring their pain to a place where people are able to go to that ball game or go out on a date or go on that vacation and not be completely crushed by it? I think we all know that in the past there was a lot more liberal use of pain medications that can become addictive and deleterious, like particularly opioids. And we still use them sometimes, but much less so. And I think for folks who are on that and needing that, our goals would be to reduce that or maybe even eliminate it entirely so that they don't have to encounter those consequences. We also aim to address psychological and social factors that contribute to the exacerbation of pain. And then we also want to educate people to do the things that they can do for themselves. There's a lot that individual patients living with pain can do for themselves that really will move the needle on their pain. And so we all of this together is kind of the comprehensive, multimodal, interdisciplinary approach to pain. All right, next slide, please. So there are so many things we can do, and I'm going to talk about them, but honestly, the general framework of what we're trying to do is in some way, shape, or form reduce the kind of flow of information going to the brain that causes pain. And so we can do that either by reducing the excitation of the nervous system, so reducing the activity, or we can increase inhibition, so there's a brake, so kind of you're putting your foot on the brake, and by increasing the brake force, you can ultimately decrease the flow of pain-producing information throughout the nervous system that reaches the brain. And so just think about that as I talk about the different things we're doing. At the end of the day, we're trying to just block that flow of information to the brain that causes pain. All right, next slide, please. All right, next slide. One more slide. We may have dropped some slides here, but I don't. Okay, something's not here. We're gonna just have to kind of roll with this. I have a slide where I talk about the toolbox. Lindsay, I'm talking about the toolbox of pain management. I'm not really seeing it here right now, but can you see if you can find it?
I can try, Dr. Chamessian, but there's a chance that it might be too challenging to do so right now in the middle of the presentation. I'm really sorry about that.
It's okay.
I'm not sure what happened there either.
I know, yeah, there's some things missing, but it's okay. We're gonna have to just roll with this. All right.
I appreciate it. Thank you.
Yeah, and there's a whole section on pharmacology as well that's I think missing. Okay, so we're gonna get just right to it. So if we can return to it later, we will. But I think, what can any physician in the world do for you? And I have basically 4 buckets. And I think framing the discussion in this way really will help us to kind of think about, when you go to the doctor, what can you actually expect? Like what is that physician working with? And at the lowest level of invasiveness, I kind of put it on I had a slide that kind of showed this, but I put it on a scale of invasiveness. The least invasive things are things like exercise, therapies, physical therapy, occupational therapy, cognitive therapy, lifestyle interventions like diet. those are all good things, and those are things that are, either driven by a patient, him or herself, or in collaboration with another clinician. The next thing that one can do is, I think, what a lot of people think of as the major tools of physicians, which is pharmacotherapy, medications. For neuropathic pain, we don't have a ton, and none of them are life changing. For some they can be effective, but the kind of medications we have are things that I'm sure this audience is very familiar with, including gabapentin, pregabalin, tricyclic antidepressants like amitriptyline, nortriptyline, SNRIs, which are selective norepinephrine reuptake inhibitors, or serotonin and norepinephrine reuptake inhibitors such as duloxetine, known as Cymbalta, venlafaxine, and then some other medications like tramadol, which is like kind of mixed opioid, and then some kind of more off the beaten path things that such as lidocaine infusions, ketamine infusions, capsaicin topical patches. Maybe we can return to that. But to be honest, I was not going to focus that much on it because I think a lot of this audience probably is receiving those things, because those are generally first line and second line therapies that any physician is able to use with their patients. It doesn't require a pain management specialist to prescribe those. But I think probably many of you experience that they may help a little bit, they may help a lot, and if they, but they also come with side effects like drowsiness, lightheadedness, sometimes bowel and bladder dysfunction or constipation. All of the pharmacotherapies that we have, I would say, have varying degrees of efficacy, often limited, and then often limited by the side effects that people experience. And so what comes after that? And that's kind of where the domain of kind of where my space is, where I can do all those things before. I work with therapists all the time. We have pain psychologists that I refer to all the time. I encourage exercise and lifestyle interventions. I use all the pharmacotherapy that I just mentioned. But when that's not sufficient, which is honestly most of the patients who are coming to me, when that's not working, then I bring out more invasive, but potentially and often more effective tools for this kind of resistant neuropathic pain. And the two that I'm going to talk to you about today are forms of what are called neuromodulation, which are either chemical or electrical stimulatory tools that can alter the way that the nervous system functions and operates. The first that I'm going to talk about here is called spinal cord stimulation. Next slide, please. Okay. Is there a slide before this one, Lindsay? Or Jane? Because I feel like we're missing we're missing some stuff here.
So I actually have a different slide deck. So let me go ahead and
if we could just pause for a second, that would be great. I know this is unfortunate, but there's a lot of stuff missing.
I understand, and I apologize about that. So let me bring it up on my screen, and I will do my best to get us to where we need to be.
Great, thanks.
Apologies. Thanks for everyone for bearing with us here.
Yes, thank you, everyone.
Yeah. All right, I am now going to start sharing my screen, hopefully. And what we can do here.
Yes, there we go. That's what I was looking for. Thank you.
Let's start from the current slide. And can you just tell me, Dr. Chamessian, if you want me to advance or go back?
Great, thank you. Okay, so this here is a slide giving you the overview of what I was just talking about, kind of the toolbox of neuropathic pain management. And for completeness sake, before moving into neuromodulation, which is what I'm going to focus on the most here, at the end of the line is structural modification, surgery. Some neuropathic conditions are amenable or require this surgical intervention. For example, or requires a strong word, but something, let's say carpal tunnel syndrome, which is compression of the median nerve through the wrist, can often be very effectively and definitively treated by releasing the kind of the the connective tissue that is compressing that nerve, a so-called entrapment neuropathy. That would actually get closer towards the kind of box of curative therapy. And I could do a nerve block or a spinal cord stimulator for this, but that's not getting at the heart of the issue when we actually have a way that we could. And so this is probably not, so surgical interventions are, I would say, not going to be applicable for the majority of peripheral neuropathic pain that this audience deals with. But for completeness sake, I like to put it here just so that this, from my view, this is the entire universe of things that a physician or a clinician can do for a medical problem. And so kind of with this shared understanding, it helps us to then outline what we can do together. Next slide, please. Next. Next. Great. So this is just a slide summarizing the pharmacotherapy that I was talking about. You can go to the next slide, Lindsay. Thank you. The pharmacotherapy that I was talking about. This is a chart from a systematic review that looked at a bunch of different medications, and these are I think the things that people are currently seeing. But what I want to highlight there on the right is that there's this kind of measure called the number needed to treat, which is the number of patients who need to be treated with specific medication for one patient to experience a meaningful benefit, typically defined as 50% reduction in pain. And you can see that for kind of first line things like a gabapentin, that the number needed to treat is like about 6. And so what that means is that only 1 in 6 people is helped by this medication, leaving the rest of them not achieving that outcome. And so this kind of hammers home what I was saying about most of the first line and even second line pharmacotherapy available for neuropathic pain just doesn't really move the needle and kind of leaves people in pain, which is why then we have to move to the next things. Keep going until I stop. Say stop, please. A little bit more. Keep going. Well, one more. And another. Great. Okay, so spinal cord stimulation. So this is in that bucket of procedural interventions. This is something that we use often. I have, for example, 2 patients tomorrow with peripheral neuropathy for whom I'll do this. This is an intervention where we use electrical wires, leads that have electrodes on them, that we place atop the spinal cord in the epidural space. People who here, for example, have had children, and during that process, you get a so-called epidural injection. That space is just outside the spinal cord, but underneath the bones, and it enables us access to put these wires or medication, but in this case wires, atop that spinal cord area in a way that is able to deliver electricity to the part of the spinal cord that mediates or that can modulate painful signals going up to the brain. And what it involves is these wires slipped underneath the bones of the vertebrae, and then ultimately a battery, so a IPG, an internal pulse generator, that delivers those electrical impulses through the wires, ultimately to the spinal cord. I liken this actually to a pacemaker of the spine, and in fact, the people who make these devices are the same folks who make pacemakers. It's a similar process of using electricity to manipulate an electrically excitable tissue for a certain outcome. In the case of a pacemaker, it's to control rhythm of the heart. In the case of a spinal cord stimulator, it's to alter the flow of information through the central nervous system to affect the way someone perceives their painful condition. Next slide, please. So who is it for? So a lot of both pharmacology and devices have so-called on-label indications, things that have been well studied and that the regulatory bodies like the FDA say this is what it's for. And these include chronic low back pain from post-laminectomy syndrome, so kind of spine surgery, lumbar stenosis, which is a condition of narrowed spinal area, neuropathic leg pain due to things like radiculopathy, which is like sciatica as people call it, complex regional pain syndrome, which is a whole topic in itself, but a very painful condition. And then finally, painful diabetic peripheral neuropathy has recently become on label. But these are not the only things that we can use it for. With sufficient justification and a little fighting with the payers, you can apply it to other conditions that have similar features. And so, for example, I have here the official Aetna kind of guidance on their site about SCS, and so expanded off-label use. So it can be used as a last resort treatment of moderate to severe chronic neuropathic pain of certain origins, including all of these, but I will highlight things like postherpetic neuralgia, diabetic peripheral neuropathy, and idiopathic peripheral neuropathy as well, having been present for 12 months or more. This definition or these criteria may change depending on the payer and the situation, but needless to say, spinal cord stimulation is very frequently used and I think thought to be very effective for neuropathic pain. Next. So does it work? That's a big topic, and I think it, just like anything, does it work depends on what are we using it for. If I asked you, does a hammer work, you would say yes for hitting nails. But if I were to say, does a hammer work, and the task was to eat your lunch, you would say no, it doesn't. And so I think what we're applying the intervention to determines whether we can say it works. And so I highlight here a recent meta-analysis, which is a collection of studying multiple pieces of literature, multiple studies for diabetic peripheral neuropathy. And the graph here kind of shows the reduction in pain score at 6 months, and multiple studies showing that you get significant reduction, so like a negative 4 there on a pain rating scale, demonstrating that at least at 6 months, and so there's some more data to show even up to 2 years and beyond that, a significant reduction in people's pain. Next slide, please. So how does it work? Complicated, but and I think being honest about it, we don't entirely know. We know that it does, but we don't entirely know. But the conventional teaching is that the electrical wire that is placed over this area of the spinal cord called the dorsal column activates axons there, so wires that then go to this dorsal part of the spinal cord, which is where you're receiving information coming from those nerves. So it all kind of meets up here. It's a big junction. And by stimulating those non-pain conducting dorsal column axons, you're able to impede the upward brainward flow of information coming in from the periphery, coming in from the nerves. This is based on an idea called gate control theory. The truth is, it's probably doing a lot more than that, and it's affecting non-neural cells as well. And there's very active area of research here. But from a clinical standpoint, the things we care about are, does it work and is it safe? And then we can kind of figure out the mechanisms later. And I'd say for the first two questions, does it work and is it safe? Yes. We're still trying to figure out the how. But I've shared with you kind of the conventional teaching. Next slide, please. Everything we do in medicine has complications, things that are undesired. So what are the things that can happen with spinal cord stimulation? Lead migration is one of the most common, meaning the wire moves and then you can lose the efficacy and the effect. We've come up with ways to mitigate this a lot now through improved surgical technique, but it still happens. Sometimes the hardware can break, the wire can break, fracturing and malfunction. Infection is a dreaded complication that, depending on whom you ask, there's going to be a different rate of infection, but like any surgical intervention, there's always going to be some risk of infection. There's sometimes pain over the site of the battery. And then device removal is you remove the device because it stops working. There are people for whom spinal cord stimulation works initially, and then as time goes on, it stops working, and so the decision is made to remove it. Next slide. So what does it look like for the patient? So this is actually one of my first cases as an independent physician, where I was working with a patient who had small fiber, very painful small fiber neuropathy. I'm going to tell you a little bit more about that case in a second, but the process looks like this. First, we meet, we have a comprehensive evaluation. I kind of work with you to make the determination of, is this therapy going to be suitable to you? But of course, my patients are always in the driver's seat. And so I lay out all the options. I share the whole toolbox, and then we decide, do we want to go here or do we want to do something else before? Do we want to do more pharmacotherapy? Do we want to do more cognitive therapy? But if the decision is made that we want to pursue spinal cord stimulation, then the next step is you have what's called a pain psychology evaluation. This is a requirement both by payers and by us to make sure that patients understand what this procedure entails and that there are no limiting kind of psychiatric or psychologic comorbidities that would make this therapy not well suited. Then, of course, we go to insurance and we say, can we do this? And the answer is sometimes yes, sometimes no. And if it's a no, then we fight for it. And sometimes it ends in we're not able to do this. But It's very difficult to predict. And then we do the procedure, and this procedure is interesting. Because it's a two-part thing. You actually get to try before you buy. So we do a trial where we put the wires through the skin, and the battery part, though, lives on the outside. We don't put it inside. And the reason we do that is because it gives you 7 days, typically, to see, does this work for me? And that's for both, me, the physician, and you, the patient, to say, all right, what does it feel like to have this? Is it actually controlling my pain? And I really like that we get to do this because you don't have to commit to an invasive surgery if this intervention is not going to work for you. And so we do this, and if it does work, 50% relief or greater, and for some the threshold is 70% or greater, then we decide to do this permanently, where we go into the operating room, we place the leads again, but now the wires and the battery all get put underneath the skin, so that if you didn't tell anybody, they wouldn't know you have this, just like a pacemaker. And then we do follow up at 1 week, 3 weeks, 1 month, and then as needed. Right, next. So to make it concrete, this was the patient I was mentioning, 37-year-old woman with severe small fiber neuropathy, very painful type of neuropathic pain. And she had tried all the things, the gabapentin, the duloxetine beforehand. She was on them. It really wasn't doing anything for her. I include on the right there a questionnaire that I have showing all the numbers that she gave to different things, like, are you burning? Is it squeezing? Do you feel like electric shocks? And it was all very high. And she's, her words, I wrote it in my note because it was so, I guess, descriptive. It says, she describes her pain as a rod on fire inside my bones, and I feel like my shins are going to break. That breaks my heart. And so, it's like, what can we do? Next slide. And so I told you that I capture this information from patients beforehand, and I do this not just to write a note, but so that I can see, is what we're doing working? And I use these validated questionnaires called promise scores that look at these different domains, and then it compares to a national mean. And you can see by all these colors, the colors mean dysfunction. And so before the trial, before we did anything, she had severe physical dysfunction. She was very fatigued. She was unable to participate in her social roles and activities, and pain was interfering with her life significantly. And then after the trial, you can see a lot of that color went away. We normalized most things. And she said, my sleep definitely improved. And then at 1 month after we moved to the implant, she said, I almost feel normal again. That, as far as pain management goes, I consider that a win. And they're not all like that. I want to be very honest about that. It's not always going to be like that. But what I hope this kind of shows you is that there is a path for some, and there is possible long-term relief for some. Next. Okay, so I'm going to pivot, and we're going to have to move through this quickly, but there are more forms of neuromodulation than spinal cord stimulation. In recent years, we've now developed systems where instead of putting the wires near the spinal cord, we put it near the nerves out in the limbs, for example, in the legs or the arm. And so this has some benefits of being less invasive, less risk of, I would say, kind of very, very severe infection of the central nervous system, but also can be more effective for certain types of neuropathic pain. Next slide, please. So what does this look like? Here, instead of putting the wire, again, near the spinal cord, we put it near a nerve target that is innervating a painful area. So here, these nerves are going towards the knee, but basically any nerve that you can see under ultrasound is really fair game. Next slide. So who's it for? Individuals experiencing pain in the distribution of 1 or 2 specific nerves and who have not found relief through conventional care. And then this, there are many indications for which it has not been studied, but there are many for which it has, including post-amputation pain, which is a type of traumatic neuropathic pain, post-herpetic, post-surgical neuralgia, nerve entrapment and mononeuropathy, and then some other case reports of other things like occipital neuralgia, post-herpetic neuralgia, etc. Next. So here's one of the first studies. This is for post-amputation pain and mixed neuropathic limb pain. And you can see here on the left, the green line is showing the numeric rating scale. When the doctor asks you on a scale from 0 to 10, what's your pain? And you can see that for these patients, it started at an average of 7. And after use of this peripheral nerve stimulator and implantation, their pain went down to a 3 and a 2 and eventually 2 at 6 months. And for those who did not get that intervention, it stayed at about baseline in the 6 to 7 range. I think most of us would consider that very successful. Can we stay back, please. I think we would all consider very successful. I also want to highlight these are averages, so this is concealing that maybe some patients their relief was more like a 5, and then for some it was maybe a 0. But I also want to highlight that 0 pain, unfortunately, is not the outcome even in the best case. So when we're talking about what we can achieve, we should have realistic goals. Because if we think that 0 pain would be great, and if we could achieve that, awesome. But if that's what we're expecting, then everything is probably going to be failure. And so it's important to have reasonable expectations for both parties. But I would say, we can poll the audience maybe just kind of informally. I think if you could go from a 7 to a 2, that would probably result in a very desirable increase in the quality of life for a lot of folks. And so that's kind of the trade-offs we're making. And then on the right is another peripheral nerve device in post-amputation pain, and you can see there as well that there is a significant and persistent reduction of what a lot of folks would call like phantom limb pain. Next. Complications similar to spinal cord stimulation, lead migration, lead fracture, infection, and lack of efficacy. Next. So what does the process look like? This is one of my recent cases for a patient with upper extremity pain. Similar comprehensive evaluation, pain psychology, insurance authorization, and then we do the procedure. And unlike spinal cord stimulation, there are some devices that are entirely temporary, where the battery lives outside for 60 days and we do stimulation for 60 days, or there are some where there's an internal implant. Typically, this is done in an office-based setting for the temporary ones and the trials, and then permanently they go to the OR. And for me, because nerves are soft tissue that are easily visible, ultrasound guidance enables us to do this safely and in a targeted way. Next slide, please. Sharing with you a real live case. So this is a young man who came to me with almost a decade of very severe phantom limb pain. He had an amputation in his 20s. Every day he was telling me that his leg felt like it was shocking and zapping him. His sleep was terrible because you can imagine trying to sleep when your leg is on fire or zapping you. And he had basically been just trying the standard pharmacotherapies, gabapentin, duloxetine, etc., not really doing it for him. And so this, where there's a distinct nerve that is targetable, is a great application of peripheral nerve stimulation. And so we did this. It's a very easy procedure. You can see it here. I demonstrate the lead, which is the wire, being right on top of that sciatic nerve, which runs down the leg. And he reported immediately 50% relief, and it's ongoing. And we're following this patient in real time right now. And not all of his pain was removed. There was still pain from the prosthetic at the site of his kind of residual limb. But all that nighttime stuff, the kind of spontaneous shocking, he said it was much improved and his sleep improved. So meaningful gains. Next slide, please. Looking ahead. So we talked about emerging options. I think for a lot of you, the things I talked about are new, and those are things that are available today. But I also want to kind of give an eye to the future and talk a little bit about what I do, actually the majority of my time in my lab right now. Improving what we can offer and improving the lives of people with neuropathic pain requires improved knowledge and the development of new therapies, which requires research. Next slide, please. So this is a table from a recent review. A lot of folks ask me, like, Doc, what's coming down the pipeline? Like, will there be anything better in the future? There are a lot of drugs being studied. It's not so if you're feeling frustrated by the fact that your doctor only has a couple medications, all of which have undesirable side effects or not helpful, it's not for lack of trying. Both in pharma and industry and academia and elsewhere, it's not for lack of trying. It's a really hard problem, but there's a lot of development now in the kind of, this is the drug space for different targets and different medications. I'm going to highlight one up there, suzetrigine, which is a recently approved sodium channel, a specific sodium channel blocker that was just approved in January. That there's a lot of excitement around, and I imagine some of you may already be asking your physicians about it. Right now, it's only approved for acute pain, meaning like post-surgical. But next slide. There is now a phase 3 clinical trial that I'm the site investigator for with one of my colleagues here at Washington University, and there are multiple sites around the country doing this, using this sodium channel blocker, suzetrigine, in diabetic peripheral neuropathy. And we'll see what those results look like, but this may be a new option for patients that is closer than not. Next slide, please. new forms of neuromodulation. So, the things that I shared with you are not to be taken lightly. They're putting devices, they're putting wires into sensitive areas of your body. I never take that lightly. And I'll also just say that that's not the first thing that I do, right? We have to have exhausted other options first before we get there. But, could we do something a little less invasive that achieves similar ends? And so there's a lot of development in the non-invasive neuromodulation space. One that I'm excited about is magnetic peripheral stimulation, where you use magnetic fields that are, applied transcutaneously towards nerves to alter their electrical signaling. I'm going to probably use this in my clinic soon, and this would be very exciting and probably very appealing to a lot of patients who aren't keen on having a wire put in their body, even if that could achieve the results they want. If they could do it in a less invasive way, I think that's something we'd all want. And then, in the invasive neuromodulation space, new device hardware, new programming, and expanded neural targets. I mean, this is there are a plethora of options right now, and it's a really exciting time for patients and physicians alike. Next slide. This is like closer than not, and maybe not for everybody, but there are some disclosures publicly about doing things permanently by altering the genes in sensory neurons that affect pain. And so, for example, there's been talk of using viral tools to reduce the expression of a sodium channel Nav1.7 involved in pain. So kind of getting closer to, I still wouldn't call this necessarily curative, but something that's so durable that it could almost be considered causal. These are the things that are on the horizon, but it's going to take a while. Next slide, please. And then I want to tell you a little bit about what gets me excited and my passion and what my lab does. So I see patients one day a week, but the other 4 days out of the week, I'm working hard with my team here to try to discover new drugs and understand neuropathic pain better so we can either prevent it or reverse it. Next slide, please. So this is kind of just an overview of my approach where, I see patients as participants and collaborators in the entire process. And I don't just see the laboratory as where I do that work. The clinical environment and the laboratory are, for me, one integrated whole. And the patients that I see are both the inspiration and the motivation for the work that I pursue. And so the patients that I work with have kind of helped me hone the questions that my lab dedicates itself to. Sometimes patients will directly engage and provide either biospecimen samples like blood, urine, skin, or just the clinical data. And then we'll bring that back to the lab and we'll do things here to try to understand why are those patients having the pain that they're having, and also go in the reverse direction. Can we come up with new things in the lab that can then be applied to the clinic? And that's kind of the cyclical diagram here. Next slide, please. So real quick, we have you can use that QR code to go look at the paper if you want, but I mentioned that, for example, suzetrigine is this new drug that we're all excited about, targeting this sodium channel subtype called Nav1.8. I think what has been achieved is very exciting, but I think there's a lot we can do better. And so my lab is working on an entirely new class of Nav1.8 targeting analgesic that I believe will have more durable, more efficacious kind of outcomes, and also perhaps fewer side effects. So stay tuned there if you'd like. Next slide. And then a new initiative that I'm very excited about is there's been a lot of development in so-called personalized pain medicine. And this is all still very research realm, but there's the potential to take, for example, blood cells from individual patients, for example, my patients with small fiber neuropathy, and to be able to create from their blood cells pain neurons, so-called nociceptors, that are specific to that individual. And then you can do things in the laboratory setting to investigate how those pain neurons might respond to different kinds of drugs or different kinds of manipulations. And then you could take those insights that you learn on that individual person and potentially go back to the clinic and say, okay, I tried 100 different FDA-approved drugs on these neurons, and 1 or 2 of them seem to suppress the aberrant spontaneous activity that is occurring in this individual person, not the average patient, but the individual person's sensory neurons. Let's then use that one. I think you'll notice that a lot of pain medicine is trial and error. Neither I nor any other physician has a crystal ball about what's going to work. And a lot of times we have to just try it. We have to say, let's try duloxetine, let's try gabapentin, let's try spinal cord stimulation. And it doesn't work. What we need to get towards is being able to predict who will and will not be a responder to a particular therapy so that we don't have to do so much trial and error and we can do more kind of precise interventions. And that's what I hope to get at in this. And the patients that I work with will very much be a part of this initiative, because I need to collaborate on the kind of getting the tissue that can do this, but then also the reverse process where I study a particular person and then we treat them back in the clinic with what we learn. Next slide. So if you'd like to, I very much see patients with neuropathic pain as being collaborators in the work that I do. And so I invite you to check out my website periodically, get in touch, to kind of follow what we're doing. And if there are things that you want us to be knowing about or looking about, I very much welcome that kind of input. And with that, I'll take any questions.
Hi. All right. Great. Well, let me unshare this screen, put myself back on camera. Sorry about that, everybody. And also sorry for the back and forth with some of the slide deck. That was not an enjoyable thing.
Thanks for handling it really well, Lindsay. Appreciate it.
Yeah, no, you did great. You did great. Yeah, like water under the bridge, right?
Yep, exactly.
So Dr. Chamessian, your lecture just now was fantastic. Lots of folks are asking for your slide deck, and the recording and the slide deck will be shared on our website.
Fantastic.
We also have a host of questions that have come through. Unfortunately, we will not have time to get through all of them, but let's try to kind of go through as many as we can in our remaining time. And again, any questions that anyone is interested in asking, please do so through the questions box. Just type those in, and again, we'll try our best. So you didn't really talk too much about light therapy, and I'm just curious what your takes are on that, specifically for painful neuropathy symptoms.
Thanks for the question. I'm going to give an answer that is going to include probably a lot of things. TENS, medical marijuana, various kinds of supplements. In general, my approach is that patients are in the driver's seat. There are a lot of things one can do for oneself. Not everything is needing a physician, and some things that do need a physician, we have maybe limited evidence about. But in general, my approach is if I sincerely believe that something will not cause anyone any hurt or deleterious consequence, I think one needs to just try. So I don't have anything specific to say about light therapy, other than I would say, as long as it isn't going to hurt you, and it's also not going to break the bank, because that often is the case with a lot of kind of therapies that aren't supported by payers and things like that. I say go for it. Same thing with if someone wants to try a supplement or someone wants to ask about medical marijuana or etc. I think as long as you don't think it's going to hurt you and it's legally obtainable, remember the end point here is relief, right? And so if someone tells me that doing X, Y, or Z causes them relief, I may not advocate for it, but I also won't say don't do it. So I don't know enough about light therapy to say one way or another, but it sounds like something that, unless you're putting it in your eye, I don't think it's going to hurt you, and hopefully is something that isn't too expensive. But give it a try, see what happens.
Yeah, and I think to your point, TENS unit, medical marijuana, to your point, if it's legal, if it's something that could help you, talk to your primary care physician or your neurologist to see if this is a treatment that you could consider. As we all know, there are no current cures for peripheral neuropathies. It's just all about symptom management. And it's kind of a combination of various therapies and lifestyle changes that sometimes are very impactful and take you from what you had referenced from a painful scale of 7 down to a 2. And that's huge. That's significant. That's the goal.
Right.
Great.
Exactly. So I will often not say no to someone. I agree with you. You should talk with your physician about it. But I think a lot of physicians share my feeling that, there might be some who have very strong feelings about something where they think it is going to harm someone. And I think that's coming from a sincere place. And if someone came to me and suggested something, I will let them know what I think. But, ultimately, if it's legal and, accessible, then I say, you give it a try.
100%. And there's a lot of information also on the Foundation for Peripheral Neuropathy's website about a lot of these treatment options that just kind of gives, general educational information about it as a resource so that you as your patient, or if you're a caregiver of someone, you are educated about what the options are, and you can have that really fantastic conversation with your primary care physician to see if this is something that will help you or your loved one. So
Right.
fantastic. Yeah. And TENS unit, scrambler therapy.
Right.
Um,
All that.
those are all fantastic options to look into. And again, to your point, as long as it doesn't break the bank or has some known side effect or something that could be hurtful, that's something then that either we would know as the foundation or one of your primary care physicians would be able to speak to. So
Yep.
fantastic. Could you talk a little bit about supplements, right? Are there
Sure.
any supplements, whether it's vitamins or other things that folks should consider, again, to manage their pain? Is there
Yeah.
a couple that kind of stand out for you?
So I would say there are some causes of neuropathy where a vitamin deficiency or sometimes excess, like for example various B vitamins, can
Yeah.
be the causal. So B12 is is one that is often identified. That's usually something that's picked up by your physician, usually a neurologist. And there, if there's a true bona fide deficiency, then the intervention is repletion, putting it back. But in terms, if that's not the case, the one I think for which there is the most study, and even there the results are, not necessarily earth-shattering, is alpha lipoic acid. In Europe in particular, there was a lot of study of alpha lipoic acid with diabetic, specifically for diabetic peripheral neuropathy. And I think there the goal is not just pain relief necessarily, but also perhaps some regeneration or kind of restoration of nerve function. Um, I have lots of patients who are on it. It's one of those things where yes, you can get it, you can try it. You don't even I mean you can try it. The side
Yeah.
effects I think the people most often complain about are GI distress, but I've not seen any groundbreaking or shattering reductions in pain from it. But it's one of those things where I think there actually is evidence for it, and I wouldn't say no to someone, but I think we have to have expectations that are consistent with evidence.
And I think also what you highlighted, and I want to kind of reiterate it to our folks listening today, is if you don't have a deficiency, please do not take that supplement. And I think that's something that is really important. Sometimes folks hear, oh, B12 could be a deficiency. I'll just load up on that vitamin on my way home from work today. And that's actually not helpful. You're possibly doing yourself a disservice. So getting those tests run and those diagnostics run to truly understand the cause of your neuropathy, and then you can address it accordingly.
Yeah, absolutely right on. And more is not better. Actually, there is a known cause of peripheral neuropathy from B6, like vitamin B6, pyridoxine, taking too much of it, right? So more is
Yes.
not always better, and you can sometimes hurt yourself with things that we generally think of as innocuous. So
Yeah.
important to kind of be kind of precise about these things and not go crazy on things just because you're looking for. I get it. I get that people want to feel relief, but sometimes you can do more harm than good.
Yeah. And speaking of tests, are there specific tests that as a pain specialist you like to run on your patients to better understand so that you can better treat their painful symptoms? Are there any
Yeah.
that people should start asking to their physicians, hey, let's run these on me?
Sure. Well, remember, this is why I had our shared definitions. Pain is an experience, right? There is no test that I have that I can see someone's pain. Only what they tell me, I take at face value. Now,
Yeah.
the reason we run tests are to see if there are causal things that we can intervene on. And I would say by the time patients are coming to me, the neurologists have usually done that because actually kind of first line, kind of the first diagnostic workup is like things like B12, right? B12 is part of that, glucose, A1C, because those are things that we can address, right? You can address diabetes, you can address B12 deficiency. I really don't do a whole lot of testing unless someone comes to me undifferentiated, where by that I mean they're coming to me from the community. They haven't seen a neurologist yet, and all I know about them, they don't even have the label of neuropathy. All I know about them is, doc, my feet are burning. At that
Yeah.
point, I will kind of take on the role that a lot of times the neurologist will, where I will do that kind of, I'll do some of the serological blood testing. I will send for electrodiagnostic studies because it is important to know, are we actually working with defined neuropathy here that is at least confirmed in the way that we can. I skipped through the diagnostic slides or not. But typically, other than getting an MRI, and I typically don't get more testing. And the reason I get an MRI is not so much because I need to know what the problem is. It's for planning for something like a spinal cord stimulator to make sure that the spinal space is accessible to my intervention. So for me, pain is not cancer. Pain is not heart disease. Like, it's an experience that is reported by another conscious human being through their words and through their actions, and that you can sometimes infer their painful condition. And so I don't do a whole ton of testing unless I'm doing more of unless someone comes to me, like I said, without having had that extensive workup where the patients usually come.
And I know we're right on the hour. I'm going to do a couple more questions, so
Sure,
we might
do.
Closing a few minutes late. I so appreciate that. So we're always talking, at least with us, nerve pain, right? That's what neuropathy is. Do you also look into similar treatment plans for joint pain or muscle pain? Because, again, neuropathy patients might have or experience other pains that are comparable.
Absolutely.
So curious if that's a similar kind of like field, or if this is a little bit outside of your purview or outside of,
No, actually, I kind of made myself a neuropathy specialist through my research and my kind of preferences over time. But throughout all of my training, I've seen, especially as a resident in physical medicine and rehabilitation, I spend most of my time dealing with musculoskeletal pain. And so, these distinctions, ultimately, a patient comes to you with pain. They say, I hurt here. And it's our job to figure out, why do you hurt? And then what is the targeted intervention? And so people who have peripheral neuropathy also can have lots of other problems too, right? So someone who, let's say, who's in their 60s and has peripheral neuropathy can just as easily have, let's say, knee osteoarthritis, just like anybody else in that age class can, or can have back pain due to the myriad causes of musculoskeletal originating back pain. And so, for my particular clinic, because I'm a specialist, the primary kind of the entry point is that someone's primary pain concern be neuropathy, but if they also happen to have knee pain or they have back pain, I take care of the entire patient and address those too.
Got it.
And in terms of intervention, and actually the toolbox that I laid out before is actually the toolbox that we have for every kind of painful condition. Non-invasive, therapies, exercise, lifestyle modifications, it's different kinds of pharmacotherapy. So for example, let's say for knee osteoarthritis, it's not going to be gabapentin so much as, let's say, aspirin, Advil, Celebrex, so-called non-steroidal anti-inflammatory drugs. And then we have various interventions too. Actually, there are a lot more interventions even for musculoskeletal pain. Things that many patients may have undergone, like certain kinds of injections, radiofrequency ablations, various kinds of minimally invasive spine surgeries or procedures. So it's a similar toolbox and a similar thinking, but different presentations, different problems, different causes.
Great. And to close out, I just have one more question. And again, I want to reiterate to everyone, I'm seeing all of the questions, amazing questions coming through. I so appreciate them. We will try our best to answer these following the program. So please know that there's going to be some type of follow-up, whether it's a part 2 webinar or just another, post on our website. We will try our best.
We can do a Q&A on the website, Lindsay, if you want. I'm down for it.
That's fantastic. Oh my goodness. I love that, Dr. Chamessian. Thank you so much. Yeah, let's do it. Okay, so great. So the last question that I wanted to ask, and I think this is actually a really nice way to close it out, because peripheral neuropathy impacts everyone differently. And the progression of the disease also changes its course depending on its cause, your age, a number of factors, a host of factors.
Absolutely.
So what do you do when there's a change of symptoms, right? Where maybe it goes from pain to numbness, or pins and needles to burning, right? How do you address those, or do you just kind of sit and wait for those types of follow-up visits and then, okay, we have something new going on, let's take a little bit of a left turn and see what that looks like? So could you just briefly kind of speak to that? Because I do know that our patients, right, today it's one thing and tomorrow it could be something else, and that's just unfortunately what neuropathy is.
Sure. Great question. So there are if someone's symptoms change, you got to put your thinking cap on and ask why. And you mentioned some of those. You did a great job of that. One, is there a new problem? Like, for example, someone could have, let's just say someone has a diabetic peripheral neuropathy, but all of a sudden starts having some knee pain. Well, do they now have a new cause? Do they now have osteoarthritis on top of their peripheral neuropathy? So if distinctly new symptoms emerge, then we have to kind of go back to the drawing board and do our diagnostic process. Like, is there another problem superimposed on the old? If it's similar issues, like let's say you said it goes from pins and needles now to now a lot of stabbing or a lot of allodynia, that just might be the natural history of that person, like the natural progression and course of a person's neuropathic disease. There's a variety of kind of history, like kind of progressions of neuropathies. Sometimes it's all at once and then a plateau for like decades. Sometimes it's going up and then wax and wane like this. For some people, it's go up to a max and then come down. There are people who spontaneously resolve. And so you have to then think, is this person's change in disease manifestations just a consequence of the kind of neuropathy they have? But I want to give one particular example where I would do something different, where I've done an intervention. So let's say I put a spinal cord stimulator into somebody and they're getting great relief. And then like 7 months later, they come back and tell me, oh, it was so good. And then all of a sudden it stopped. So that to me could mean either their body has adapted to the therapy, which happens. I liken it to walking into a room with a very strong smell, right? It hits you in the face when you walk in the room, but the nervous system adapts, and then all of a sudden you're there for a little while, and the smell is still noticeable, but not nearly as much. We're applying electrical stimulation, which is a stimulus to the nervous system, just like any other. It's an artificial one, but we're doing it. The nervous system can adapt, which the nice thing about these neuromodulation devices is that we can program. It's like television now. You get 1,000 channels. You can program them in different ways to try to like get ahead of the nervous system adapting. But let's say all of a sudden their pain comes back and it's like really severe. Then I have to ask, did one of those complications happen? Did the wire move down? Did the battery stop working? Is there a lead fracture? And this actually happens. I had a patient do a trial the other day. She was getting great relief over the weekend. She was like, wow, this is great. Saturday, Sunday, Monday. And then all of a sudden on Tuesday, all of her pain came back. And so we could have just kind of, brushed our hands and been like, okay, this isn't going to work for that person. But I went and I got an x-ray and I saw the wires had moved down significantly. And so in that case, it was a device complication malfunction that resulted in her loss of efficacy. And so that's typically where I'll do some investigation to figure out, why is this person no longer getting relief?
And I think to kind of, as we conclude, I think a lot of what you've spoken about and some of the Q&A that we've done just now, right, it shows that your neuropathic pain is going to progress. It might get worse. It might get better. There's a lot of different options out there for you to consider. Yeah. And what's brilliant and fantastic is there's research happening right now. There's research that, I know that our organization is funding right now, and I know that your lab is doing. So I'm hopeful, and I want all of our patients to also feel that hope, right? That tomorrow is a different day. It can also be a better day. And just because you've been experiencing pain, then start asking some questions. Just go see your neurologist again. Try to find a pain specialist. Keep advocating for yourself, because you can hopefully find something that gets you out of the rut and goes from that 7 to that 2. That's the goal.
Exactly. And if we can't get rid of the disease, you can live with the disease. Almost as like if you were to find a way where you don't even notice the disease that you have, okay, fine, you still might have this problem, but ultimately what you really care about is this affecting me, right? Not like, what label do I have? And I think we can get people living with a chronic disease, even if we can't cure it, in a way that allows them to live the lives they want without suffering.
Correct. And that is exactly our organization's mission. Dr. Chamessian, thank you so much for pitching that for me.
Fantastic. I read your mind.
Yeah, so that's our goal here, right? We're trying to get everyone to a better place and live the best life that they can. And we're advancing research. We're hopeful that answers will be made available tomorrow that weren't today, and that we keep progressing. And with that progression, Yeah. So that's the goal, and that's why we're here. And Dr. Chamessian, again, thank you so very much for this. This has been
My
amazing. We're
pleasure.
definitely going to do, a follow-up Q&A through our website. So please all stay tuned. I'll make sure that that's highlighted in all of our electronic communication. So I
Yeah,
really
a lot of
encourage
fun. Let's do it
everyone,
again.
yeah,
Let's
to
do it again.
sign
It was a
up.
lot of fun.
We've had fun despite some of the technical issues. We still
It's all
have had
good. It's real life. This is real
fun.
life. We're doing it. We're doing it. Real life here.
That's great. Well,
All right.
again, thank you, Dr. Chamessian. Thank
All
you
right. Bye,
all for
everyone. Thank you for
joining
your
us.
time.
Thank you all for joining us today. There will be a survey at the end of this program. I encourage everyone to take it. It allows us to make sure that we are on point with our programs. Actually, could we go to the next slide? It has a little bit of information over about that.
Great.
So thank you so much. There's our contact information, and obviously you know where to find us, everyone. And we hope that you will continue to support us. This allows us to do the fantastic programs that we do every day, inclusive of funding research, advocating for our patients, and supplying the educational resources that I think are really valuable to this group. So thank you very much. Have a great day, everyone.
Right on. Take care. Thank you
All
all.
right. All right. Bye.